Hello, we are going to be talking about the sonographic evaluation of ectopic pregnancy in the next 30 to 45 minutes. And the outline and objectives of this presentation are to discuss the ultrasound technique for the evaluation of ectopic pregnancy, to review the ultrasound findings, and discuss common pitfalls as well as unusual locations for ectopic pregnancies. And the way that these patients present typically is with pain and vaginal bleeding in the first trimester. And whenever such a patient comes into the emergency room or the clinic with pain and vaginal bleeding, the first question that you need to ask is the patient pregnant? And if the answer to that is yes, the primary thing that you need to exclude is whether or not she harbors an ectopic pregnancy. If she is not pregnant, you will then evaluate her for the following etiologies, such as hemorrhagic ovarian cysts, ruptured ovarian cysts, ovarian torsion, or pelvic inflammatory disease. And these topics have been covered in other lectures on the website. Regarding ectopic pregnancy, in the United States, it accounts for approximately 2% of all pregnancies, and this incidence has been increasing over recent decades. And the reason for this is that there has been an increase in the size of the patient population with risk factors for ectopic pregnancies, but also because we are now diagnosing these pregnancies earlier with endovaginal ultrasound, and therefore we likely identify ectopic pregnancies that would have resolved spontaneously without coming to medical attention before the advent of use of endovaginal ultrasound. The risk factors for ectopic pregnancy are listed on this slide, and the most important include any history of prior ectopic pregnancy, pelvic inflammatory disease, history or treatment for infertility, and tubal surgery. But if a patient has an IUD or endometriosis, or in the older woman or a woman who has had a prior cesarean section, the risk of ectopic pregnancy is also substantially increased. Now, while the incidence is increasing, the mortality of patients with ectopic pregnancy has been decreasing, and this is also due to the fact that we are now making the diagnosis earlier with endovaginal ultrasound, and therefore these patients are coming to medical attention before they become hemodynamically unstable. Nonetheless, ectopic pregnancy remains the leading cause of pregnancy-related death in the first trimester. In terms of technique, the gold standard for evaluating the patient to exclude ectopic pregnancy is endovaginal ultrasound. And the reason for this is that this gives the best spatial resolution for evaluation of the adnexa. That being said, you do have to pay careful attention to optimizing your technique, and you want to use the highest frequency transducer that is available. You want to optimize the focal zone so that it is just at the level or just below the area that you are interrogating with the ultrasound beam. You want to use any tricks that your high-end equipment might have that would improve spatial resolution, such as harmonic imaging or spatial compounding. And don't forget to magnify the images, particularly if you're looking at the endometrial stripe and the adnexa. We suggest using a bimanual approach when you're evaluating the female pelvis. And by that, what I mean is that you want to palpate the anterior abdominal wall with one hand as you're holding the endovaginal probe with the other. And this will help move the gas and the artifact from the gas in the bowel out of the way so that you can visualize the organs in the pelvis better. It pushes the area of interest towards the transducer, which will improve visualization. It also helps to identify the area of the patient's pain, which is where the pathology is likely to be. And it is a very useful technique to try and separate a tubal mass or ring from the ovary. And if you can identify that these two structures are separate, you can be sure that the tubal mass is in fact an ectopic pregnancy and not simply a corpus luteal cyst arising from the ovary. In addition to evaluating the endometrial stripe and the adnexa, you always want to examine the cul-de-sac carefully, as this is the most dependent portion of the pelvis, and therefore where ectopic pregnancies not infrequently drop. And you want to use Doppler selectively in the first trimester as a last resort for evaluating the adnexa and occasionally the endometrial stripe. Now, while we focus our exam on the endovaginal component, transabdominal scanning is a required part of the protocol. And the reason for this is that you need transabdominal scanning to assess the upper abdomen for the presence of free fluid, and this will help quantitate any hemoperitoneum that you might have identified in the pelvis. This is extremely important in terms of determining the hemodynamic stability of the patient. In addition, you want to use transabdominal scanning to look for any adnexal mass that might have been missed on endovaginal scanning, particularly masses that are higher, perhaps displaced out of the pelvis. And anytime you've not been able to visualize the ovaries or the area of the patient's pain on endovaginal exam, it is worth looking with transabdominal imaging in order to more fully appreciate the upper pelvis and the adnexa. And lastly, after you've done your ultrasound, it is extremely important that you correlate your findings with the date of the patient's last menstrual period, the serum beta-HCG level, as well as her symptoms. And we all must recognize that occasionally ultrasound will be negative and follow-up examination may be required to confirm the diagnosis. Well, in a patient who presents with pelvic pain or vaginal bleeding who is pregnant, you must consider the diagnosis of ectopic pregnancy. But the fact of the matter is that when you do your ultrasound examination in these patients who have a clinically suspected ectopic pregnancy, most of the time what you end up doing is documenting the presence of a normal intrauterine pregnancy. It's estimated that about 70 to 90% of all patients with clinically suspected ectopic pregnancies in fact turn out to have an intrauterine pregnancy. So it's extremely important that you understand how to make the accurate diagnosis of an intrauterine pregnancy in the first trimester. Because if you can make this diagnosis, this makes the likelihood of a concomitant or heterotopic ectopic pregnancy extremely unlikely. In the general population, this occurs in probably only 1 in 7,000 pregnancies, but you must understand in patients who've undergone assisted reproductive techniques, the incidence is much higher and may in fact reach an incidence of approximately 1 to 3 in 100 pregnancies. But in the normal population, if you identify and diagnose an intrauterine pregnancy, it pretty effectively excludes the diagnosis of an ectopic pregnancy. So while I know this has been covered in prior lectures, just to review very quickly how you diagnose an intrauterine pregnancy, the first thing that you're going to be looking for temporally is the presence of the intradecidual sign. And this is the presence of a cystic structure within the endometrial cavity. It will have an echogenic rim, as you see in these two cases, and it will be located eccentrically, not within the endometrial cavity, which is identified by this linear central echogenic line, but it will have burrowed into either the anterior or posterior layer of the endometrium, and therefore it will be eccentric. And this has been determined or termed the intradecidual sign. And while it is suggestive of an intrauterine pregnancy, it is recommended that you do get follow-up to document the appearance of the yolk sac, because it's really only once you see the yolk sac that you can have 100% confidence that that little cystic structure in fact represents an intrauterine pregnancy. Later, you might identify the double decidual sac sign, and this is a description of the following appearance, where you have concentric echogenic rings. The innermost ring, which will be a 360-degree echogenic ring, represents the chorion or the decidua capsularis. The outer echogenic ring, indicated by the red arrow here, is typically incomplete, not 360 degrees, and that represents the decidua vera. In between these two echogenic rings, you'll see a little bit of anechoic or hypoechoic material representing either the endometrium or some fluid within the endometrial canal. And once the beta-HCG is greater than 1,000 to 2,000 units using the international reference preparation, you ought to see an intrauterine pregnancy on endovaginal examination, and this corresponds to approximately a 5 to 6 weeks gestational age. So if you are left with a situation of a patient who has a positive beta-HCG with a level greater than 2,000 and an empty uterus, an intrauterine pregnancy is therefore extremely unlikely unless the patient has multiple gestations or the examination is technically limited. And therefore, you need to correlate with the dates to make sure that you're not dealing with a very early intrauterine pregnancy with multiple gestations. Of course, patients with multiple gestations will have a higher beta-HCG level for any given gestational age. You also want to check for a history of vaginal bleeding, and if there is no history of vaginal bleeding, miscarriage is unlikely. So again, to reiterate, if your beta level is greater than 2,000, the uterus is empty, there's not significant risk for multiple gestations, you have a good exam, probably you're dealing with an ectopic pregnancy.